Rewarding careers, experiences of a lifetime. Explore travel PT at aureusmedical.com. AUREUSmedical.com.
NPTE StudyCast.
Welcome to NPTE StudyCast, taking a look at all the various parts that come together for the NPTE and how we can make it a little more enjoyable to get past that test. On the show today is Matt Tuttle. Matt, welcome to the program.
I appreciate you having me back, Jim. Really looking forward to it.
We're looking at something around the knee area, and who better to have on the show than somebody who works in the NBA. Players always taking care of their knees. And what are we looking at? What pathology are we going to cover today?
For sure. I'd like to talk a little bit more about patellofemoral pain.
Patellofemoral pain, the term gets thrown around a lot, but when we're describing it, how do you describe that pathology?
Yeah, I would say that really it's used as a catch-all diagnosis a lot of times, even though that's not really what it was meant to be. We've seen some of this kind of tease out in journal articles and the clinical practice guidelines about best practice for anterior knee pain, where patellofemoral pain is really discussing the interaction of the patellofemoral joint and not just knee pain. Generally like an overloading or stress syndrome to that joint interaction.
Anatomy.
Next up, we look at what's involved. I'm taking a wild stab at this and saying something has to do with the patellofemoral joint.
Oh, yeah. So I would say that in its purest form, it's really just a joint problem, but the adjacent structures, of course, are all included in that, right? Whether it's the quad muscle, quad tendon, the bursa of that area, even down into the patellar tendon, and then any of those other structures on the anterior knee that sometimes get lumped into it, like a medial patellofem ligament. In its purest form, the joint, but there's a lot of other contributing factors in that area that can be mistaken for this kind of pain.
Special tests.
Proving and disproving. How do you start to localize things here in the patellofemoral pain area, Matt?
Yeah, for me, I look at this more as a diagnosis of exclusion. I want to make sure that I check all my other boxes so I don't miss anything. For me, I try and rule out anything like high-risk acute injury diagnoses, which would be like more of an ACL, a patella fracture, a meniscus injury, any other acute concerning injuries to that area, and then getting into some lower risk diagnosis. So is it just a patellar quad tendinopathy? Is it a sprain strain kind of moment? And then once I feel like I've checked all of those boxes, is trying to stress that patellofem joint, whether it's through motion or just palpation around that area to see if that's the real structure that may be eliciting the pain.
And that kind of covers differential diagnosis because it's really of a rule in, rule out. It's proving and disproving by elimination, as you mentioned.
Yeah, absolutely. Differential for this one is crucial.
Treatment examples.
All right, so once you've ruled this in, once you know you're working with an individual with patellofemoral pain, what are some treatment examples? What do you start to do with that individual as a PT?
I think the treatment approach is generally to utilize some form of manual therapy directed at like any restrictions you may find in that area, whether you feel like this is a real joint-based issue, like do we need to mobilize the patellofem joint? Is there maybe a soft tissue restriction in the quad and the gastrococcolius complex that may be contributing to this? And then for me, the big answer is how do we monitor load and stress on this region? So as we mentioned earlier, this is generally a load-related problem. So do we decrease their, say, running capacity for a couple of weeks to try and decrease their pain and then have a logical build back up? Is it we need individuals to be stronger to take on the stress that they're currently putting through their body? So I think considering kind of a load management and strength approach to this is the best way to attack it.
Here's your example question.
Students love the sample questions, always want to think they can get a handle on how this might pop up on the NPTE. So if we were to have a sample question for this, what would you throw at the students?
Which of the following is most likely a contributing factor to insidious onset patellofemoral pain? And your kind of four options here would be either A, a hamstring strain, B, a 15% decrease in running mileage per week, C, a 15% increase in running mileage per week, or D, no change recently in running mileage.
All right, so hamstring strain, 50% decrease in mileage running per week, 15% increase in running mileage per week, or maintaining current running mileage. Those are your four options. Where's your head go? Correct answer on the sample question here, Matt?
Absolutely. I would say C, right? So any significant increase in running mileage, 15% would be teetering on that edge, could definitely elicit some of these symptoms, especially depending if you get really far into the weeds on their strike pattern, on their their running form, conditions that they're running in, whether it's maybe asphalt or dirt. So there's a lot more to it, but the good answer here would be C, a 15% increase in running mileage.
Perfect. And that goes back to the beginning of this episode where we described the pathology. Pain often due to overloading or stress on the region, and a 15% increase could elicit that patellofemoral pain. We're going to have an infographic for this episode available online, so you get the show notes of this episode, however you download it. Look there, give that a click, and you'll have a visual along with this audio. Matt, appreciate your time overlooking patellofemoral pain with us today.
Thanks, Jimmy. Hope to talk again soon.
Download free study guides now at aureusmedical.com/NPTE StudyCast. aureusmedical.com/NPTE StudyCast. Rewarding careers, experiences of a lifetime. Explore travel PT at aureusmedical.com.
NPTE StudyCast. Brewed by the PT Pintcast.